Hey, it's Dr. Hervey here. I wanted to come in and talk to you about something that keeps coming up. It's coming up quite a few times in the past week. And it's my patient in labor asking me, is she on a clock? And I always answer in the same way, and I want to give you my answer today. My first answer is no, you're not on a clock. I always go back to that patient who comes in at 30 weeks pregnant, ruptured membranes. What is it is the standard of care? And all my colleagues would answer is to keep them pregnant. We would start magnesium, we would start some latency antibiotics, and we would put them in antepartum and try to keep them pregnant. The key thing that we do in those instances are, we give steroids as well, I'm sorry. The key things that we do in those instances are, we don't check the cervix. We check it that one time upon admission, whether it be by simply looking by sterile spec, or if there's an indication for a digital exam, we'll do that one exam. And then typically we don't check the cervix again until labor ensues. It's very clear to me that the multiple exams is the highest risk of infection. Therein is the concern for a clock infection. If we can keep our hands off, the risk of infection goes way down, and there's no need for a clock. Limit the exams. But then you can think of other ways and other instances where this term clock comes up. I regress all the way back to my training where we talked about Friedman's curve. Cervix should change 1 centimeter every 2 hours, and someone who's had babies before, multiparous, or 1 to 2 centimeters every 3 to 4 hours, and someone who's not had a baby, that's a prima gravida patient. Either way, there's been a lot of data out there to say that the Friedman curve, though it's a great tool, it is not necessarily the golden rule. There's a lot of different variabilities for which labor progresses, whether it be the positioning of baby, the ability to get good steady contractions going, whether it be fibroid on a uterus, or there's a history of a leap or some other surgical procedure to the cervix that might cause some scarring, and that needs to be broken up first. All these things matter to that labor curve and should be considered in our decision making. It does bother me that that term clock is so pervasive in our community, because what it suggests to me is that there are providers out there who will say, well, it's been 4 hours and you haven't changed your cervix, so we should just move towards C-section, versus that of making sure that there was lots of movements and changes and rotations and maximizing our contractions in various ways, rupturing membranes, etc. It suggests to me that if someone comes in and they broke their bag of water 12 hours ago and haven't started labor, that if not in labor in the next 6 to 8 hours fully, that again, colleagues would suggest we should move towards a C-section versus that of keeping our hands off, but utilizing our tools to induce a labor pattern for the patient. So again, I just want to come back and say there is no such thing as a clock. There is clinical judgment, and I do respect my colleagues' clinical judgment when it comes to labor progression, when it comes to necessities to transition care. But at the same time, there is no such thing as a clock.